Welcome. I'm Dr. Lauren Cochran, Director of Clinical Faculty Development at CUNY School of Medicine. In this video, we'll share 7 strategies for teaching clinical reasoning. To start, it's helpful to remember that clinical reasoning guides several distinct phases of a medical encounter. First, we generate hypotheses, usually based on the chief concern, to direct further data gathering. Next, we refine and test those initial hypotheses through the data collection process. And lastly, we finalize our diagnosis or characterization of the patient's problem and then develop a plan. This is important to remember and communicate with our trainees that clinical reasoning does not stop once the diagnosis is established. Our first strategy, allow time to prime. The process of clinical reasoning for early trainees is slower and more deliberate compared with seasoned clinicians. And throwing them into an encounter without a chance to activate their previous knowledge will limit the growth and learning potential of that experience. Let's say you're working with an early third-year medical student in clinic or the emergency department and see that a patient has just been triaged with a chief concern of sore throat. You could say directly, "Why don't you spend 5 minutes thinking and reading about sore throat before you call your patient back? Try to think about a broad differential and what are the most important facts to gather with your H&P." Or if time allows, you could spend a couple minutes engaging directly in this conversation with the student. Next, ask, and ask again. We can't diagnose strengths or gaps in a learner's clinical reasoning if we don't understand their current thought process. For example, what about this patient's presentation is making you think of Lyme disease? Is there anything that doesn't fit well with Lyme? Which other diagnoses did you consider and why? We have a separate video on our channel about the 1-minute preceptor teaching technique that specifically emphasizes this process of probing for supporting evidence. Next, when a student is having trouble expanding or organizing their differentials, it can be helpful to provide structure. This could be very simple, such as encouraging them to come up with the 2 most likely options plus 2 can't-miss diagnoses that need to be ruled out. Or you could help them utilize a mnemonic to facilitate broad differentials, such as vindicate. One of my favorite strategies is compare and contrast, where we encourage our students to study diseases in a way that promotes clinical reasoning rather than rote memorization, such as reading about 2 to 3 diseases at the same time, comparing and contrasting their features. For example, a student might read about the presentation of scarlet fever versus Kawasaki disease, specifically assessing the commonalities and differences. Another tip is to emphasize the epidemiology. You may find that early clinical students suggest more zebra diagnoses and sometimes lose sight of the horses. How can we guide them? Sometimes it's helpful for learners to simply look up key epidemiologic data, such as prevalence or incidence, for the diseases they're considering. Or maybe a student fails to recognize how significantly a specific risk factor influences the likelihood of a certain disease. For example, a student may have learned well that pyloric stenosis typically presents as an infant with progressive, non-bilious, postprandial vomiting, but they may not know that presentation after 3 months of age is very rare. Another idea, we definitely want to give our learners the opportunity to reason through cases themselves, but it can also be incredibly helpful for them to hear an experienced supervisor talk through their own clinical reasoning for a case. Really just thinking out loud. For example, when I'm seeing a patient with acute onset joint pain, the first thing I'm thinking is trauma, and I want to understand exactly how and when the pain started. Also, I always keep infections such as septic arthritis in mind as I can't miss, so I ask about symptoms like A, B, C, and D, and so on. Lastly, ambiguity and uncertainty are part of the practice of medicine, and clinical reasoning is just as important here. As an example, let's say you're seeing a patient with either nummular eczema or tinea corporis. You could help your student think through the options. What's likely to happen if we prescribe a topical steroid for eczema, but it's actually tinea? Or the opposite scenario. Or should we wait on treatment until the patient can see dermatology? What's likely to happen for the patient if the next appointment is 3 months away? And so on. I've listed my references here, and I thank you very much for watching.